Thank you all for being here. Good afternoon. I'm Cynthia Benz, and I serve as Senior Vice President of Public Policy at the Personalized Medicine Coalition. For those of you who aren't familiar with the Personalized Medicine Coalition, we're a nonprofit organization that's made up of 220 member organizations from across the healthcare space. So we have patients and patient advocacy organizations, research and clinical care institutions, large and small diagnostic companies, large and small biopharma companies, health IT companies, a payer, and others who are in the healthcare space. What joins us all together is that we're all working together to accelerate a paradigm shift to personalized medicine. Many people define personalized medicine various different ways, but the definition we use is that it's a field in which physicians use diagnostic tests to determine what treatments will work best for each patient, or to use medical interventions that alter molecular mechanisms that impact health. So when we use that term, it's to refer to things like cell and gene therapies. We all feel that personalized medicine holds great potential for reducing trial and error approaches to care by better aligning treatment and prevention plans with data from a patient's diagnostic tests, their medical history, their circumstances, and values. Kevin Hines is one of the most famous suicide attempt survivors in the world. For those who don't know him or know his story, he jumped off the Golden Gate Bridge and survived. About his experience with mental illness, he says, "I was in too much pain to reach out, so I needed someone who could notice me and reach in." Many of us are touched by mental illness from personal experiences or through the struggles of somebody we know. And it's clear that we may never have enough mental health professionals to help all those that are hurting the world. We need to explore and leverage every solution to address what has become a mental health crisis in this country. Approximately 60 FDA-approved medications are impacted by genetics, and that's just in the mental health space alone. These drug-gene interactions can affect the efficacy of drugs, can spur adverse events, and if left undetected, it can lead to a time-consuming and expensive treatment path for patients and providers before they can identify appropriate treatment regimens. Pharmacogenomics, or PGX for short, is the study of how a person's DNA impacts individual treatment response, and it's an important tool for patients and healthcare providers in utilizing personalized medicine for the treatment of mental illness. The bipartisan, bicameral Congressional Personalized Medicine Caucus is made up of members who are seeking to ensure that healthcare policies that are taken up by Congress consider personalized medicine. Since its launch in early 2020, before the pandemic, the caucus has partnered with the Personalized Medicine Coalition and its allies to host briefings like the one we're having today about the importance of advancing personalized medicine for the benefit of patients in the healthcare system. And we don't always have ice cream, but we're planning to do it in the future, so hopefully you'll enjoy the content and the snacks. The leaders of the Personalized Medicine Caucus are also working with their colleagues to advance legislation to help address the burden of mental illness in this country. Among these efforts, Senator Tim Scott and Sherrod Brown are advancing bipartisan legislation that would require CMS to provide states with best practices to improve outcomes for Medicaid-eligible individuals with mental health conditions by helping to increase access to genetic testing to inform their treatment options. And just to put it in perspective, nearly a third of low-income Medicaid beneficiaries have been diagnosed with mental illness. Representative Eric Swalwell has also been working on trying to reintroduce a pharmacogenomics legislative package. And if you're interested in learning more about that, Lucas Lamb is here from his staff and will happily answer any questions. And you'll be hearing more about that from Representative Swalwell in a second. But really the purpose of it is to try to harmonize activities across the federal government as it relates to mental health and have some recognition for pharmacogenomics as part of that. So it's Fly Out Day. I attribute that to why the turnout is so good. Many of your bosses have left town already, and some of the caucus co-chairs are in the air right now as we speak. So I have a couple of recorded marks that I'm going to play, and after that I will move on to the introduction of our speakers. So let's see if the technology is going to work. First, we're going to hear some remarks from Senator Sinema. And I played it.
Hey, everybody. I'm Congressman Eric Swalwell. Thank you for attending the Congressional briefing on personalized medicine, pharmacogenomics, and mental health. This topic is so important to me, and I've been working with colleagues across the aisle on pharmacogenomics legislative packages that will start addressing some of the issues in healthcare that you will hear more about today. My legislation, the Right Drug Dose Now Act, enables the use of evidence-based pharmacogenomic testing to prevent adverse drug events, ensuring that drugs are safe and effective for each person. Pharmacogenomics is the practice of using the relationship between genetic variations and how our body responds to medications to effectively prescribe medications. Specifically, pharmacogenomics can be a very helpful tool in optimizing medications used to treat a range of diseases and conditions, including cancer, mental health conditions, and opioid use disorder. That's exactly what the Right Drug Dose Now Act would help with. Understanding the drug-gene relationship enables healthcare providers to prescribe the medications most likely to benefit the patient while avoiding or adjusting the dose of other drugs to prevent negative side effects. This is so important, especially when adverse drug effects, believe it or not, are the fourth leading cause of death in America. Studies have also shown that almost half of adverse drug events can be prevented, and that over 99% of the population could have at least one genetic variant that impacts how their body responds to a medication, making broader adoption of pharmacogenomic testing a critical piece in improving health outcomes. It's very important, especially for those taking mental health medications, and I'm committed to working with my colleagues to improve all patients' quality of care. Thank you, thank you, thank you again for your continued support and participation in our educational briefings. And please, enjoy the ice cream.
The ice cream is the worst kept secret in Washington. Okay, now I'm going to play the Senator Sinema's remarks.
Hello, I'm Kirsten Sinema, Arizona Senior Senator and one of the co-founders of the Congressional Personalized Medicine Caucus. Thank you to everyone attending today's briefing, focused on how personalized medicine and pharmacogenomics can help make healthcare work better for people living with certain mental health conditions. We know that healthcare, especially mental health care, can be incredibly complex. What works for one person may not work for another person, even if their mental health needs are similar. That's where pharmacogenomics can help. This is the study of the interaction between our genes and the medications we're prescribed, and how well we as individuals may respond to a specific treatment. The effects of a drug or medication can vary greatly between two people. The variation in our individual genes can impact how well certain treatments will work for us. Sometimes these variations can impact how well we process certain medicines, which can impact efficacy as well as the risk for harmful side effects. Personalized medicine can help providers, patients, and Medicare, the VA, and insurers figure out the right medicine at the right dose for the right patients. That's why I'm proud to have GTI Laboratories and Blue Jeans represented on today's panel, an Arizona company that's looking to make these tools more readily available, accessible, and understandable for patients and physicians. They're working to reduce the risk of adverse drug reactions, decrease harmful drug-to-drug interactions, and ensure you're getting the care that will be most effective for you. Seeking help for mental health conditions is hard enough, and patients already face barriers in being able to access care, and there's no magic fix for all patients. But utilizing innovations in precision medicine can help reduce costs, help patients get the right treatments at the right doses, and with less trial and error. I'm excited about today's conversation, and I look forward to working together with our advocacy partners in the Personalized Medicine Coalition to move our nation's healthcare goals forward. Thank you for attending today's briefing.
And we're sorry they can't be here, but we appreciate them sending those remarks and also for their leadership of the coalition. And Sylvia and Lucas, your bosses have been really great partners, so we appreciate that. Okay. So the panel today, here it's a distinguished panel of experts. They're from the industry, the research and provider communities, the patient community, and really can look at all facets of the issue that we're here to talk about. They're going to share some perspectives on the mental health crisis in the United States, also provide their thoughts on how innovations in pharmacogenomics are starting to move the needle on improving treatment selection and symptom management. And then we'll close by answering any questions you have on the panel discussion. So joining us are Nathan Tatro, Vice President of Alliance Development and Mental Health America, Dr. David Aslan, Director of the VISN 4 Mental Illness Research, Education, and Clinical Center at the Philadelphia VA Medical Center, Dr. Carson Felkel, a psychiatrist and medical director of behavioral health at Bon Secours Mercy Health System, and Nick Limcher, CEO of GTI Laboratories and Blue Jeans. So welcome, and thank you all for being here. So first, I'd just like to ask each of you to take a moment to say a few words about yourself and the organization that you work for, and also just offer some initial perspectives on the state of treatment for individuals with mental illness that you serve. And we'll start with Nathan and just go down the line.
Sure, great. Can you hear me? Good. Thanks for having me today, and thanks so much for the Personalized Medicine Coalition and the Caucus for having us. So Nate Tatro, I'm VP of Alliance Development with Mental Health America. Just a little bit about my background. I've worked in mental health for about 20 years. I have a graduate degree in applied developmental psychology focused on developmental psychobiology. I've worked inpatient care, residential care, geriatric dual diagnosis, and pediatrics. And then after that, I moved from direct care service into policy. So for about 4 years, I worked for the American Psychological Association, starting off working on issues like electronic health records. And if those of you old enough in the room to remember what SGR is, I worked on the sustainable growth rate and the transition from volume to value in care, maybe not. And then more recently than that, you remember, don't you?
Yeah, very much.
More recently than that, I worked for the American Psychiatric Association as Deputy Director of Digital Health in their policy shop, working on regs and legislative issues on digital health, telemedicine, AI, EHRs, electronic prescribing. And then now in my role at Mental Health America, I work on strategic alliances with both industry and nonprofit partners, and I'm really happy to be here today. If you're not familiar with Mental Health America, I've been there for about a year and a half. We're a community-based nonprofit founded in 1909. We focus on three main points: the mental health of all, mental illness, and general well-being. And everything we do, all the work we do, we make sure that the patient voice, the person with lived experience, is in the center of all these conversations. And that patient voice really drives all of our programmatic work. So we have a really robust public education and awareness mechanism at MHA, including if you're, a couple months ago, if your brain can stretch back that far, we had May as Mental Health Month. Mental Health America founded that in 1949. We also have a very big prevention and screening and research program, MHA. So most notably, we have 12 or 13 now mental health screens that anyone can take online, free, anonymous, empirically validated, for conditions like depression, ADHD, trauma, PTSD. And we get about 20,000 screens per day. And last year we received 6.5 million screens, not just from across the country, which makes up about half our screens, but across the world. So we have a really robust public health data set related to mental health. And again, all the work we do comes out of that and filters into our policy and advocacy work. In terms of the state of mental health, we've been hearing that now for quite a few years, that we're in the middle of a mental health crisis, right? The MHA, in partnership with several organizations, I think NAMI's in the room. NAMI was a part of the Bowman Family Foundation report that I think just came out maybe within the past week or so, highlighted a couple of these statistics where from 2008 to 2018, we saw an 8% jump in people being diagnosed with a mental health disorder, 24% with a severe mental illness. And then during the pandemic in 2021, we saw almost roughly a quarter of Americans being able to be diagnosed with mental illness. So that's those are pretty big numbers, and so we're in the middle of a mental health crisis. But what does that mean? Why we're here with the Personalized Medicine Coalition? There's a really big appetite for new and novel treatments and solutions to this ongoing mental health crisis. Mental Health America right now, we just recently launched our strategic plan, which we're calling Next Gen Prevention or Next Generation Prevention, focusing on these different innovations in care. The pandemic really opened Pandora's box when it came to, say, telehealth. And if you were on the Hill before the pandemic, people almost looked at telehealth as it were this niche issue that no one would ever get behind. And then look what happened when all of us were confined to our homes. So MHA is really beginning to explore these novel interventions, these novel solutions to this ongoing mental health crisis. And we know just based on the numbers I mentioned that it's much needed. So that's me and that's MHA, and I'll pass it down the line.
Okay. Dr. Aslan.
Great. So thank you for having me. Thanks, Cynthia, for inviting the VA to the table. So I'm David Aslan. I'm a psychiatrist. I've been practicing about 30 years, so I'm one of the older folks here now. my day job is to run the mental health program at the Philadelphia VA, or the Michael J. Crescent, School for Michael J. Crescent VA Medical Center. But I also run a research center there. The VA funds about 25 research centers in the mental health field. Our center is actually focused on personalized mental health care. So we do a number of studies and research in the area of can we bring personalized mental health care to patients in practice. One of those studies that we'll get into in a few minutes is currently the world's largest study of PGX utility in patients with depression. So we can get back to the details of that. But we're also very interested in lots of other ways of thinking about personalizing care. So things like asynchronous data collection, patients self-monitoring at home, but how do we get that back to the provider in a way that they can use it? Is your Fitbit, I see a couple of people here with Fitbits on or whatever brand you wear, is that data useful for us in terms of treating people for mental health care? We know there are associations, for instance, with activity and severity of depression. So can we leverage that data to actually help patients get better or encourage them to have more steps or walk or be more active? So there's a lot of different ways that our center thinks about personalized health care, personalized mental health care. And just I'm glad to be here, be able to answer questions and talk about the study a little bit.
Great. Thank you.
Good afternoon, everyone. I'm Carson Felpel. I'm a child, adolescent, adult psychiatrist. I run a service line for a really big health system, Baltimore Mercy Health. We're in 6 states, about 65,000 employees, 50 hospitals on the East Coast. So inpatient psych, outpatient psych, integrated care. Primary care prescribes 70% of our country's psychotropics. So I discovered early as a psychiatrist, if I could just help primary care providers just do it one notch better, I could affect a lot of change. Over the pandemic, I really pivoted to taking care of my own colleagues, physicians. They're burned out and everyone's really hurting. It's so helpful hearing those statistics. I would encourage you all, if you're worried about yourself, go to MHA and take a self-assessment. I do it frequently.
MHAscreening.org.
Yeah. In healthcare, we're so burned out, and I can make the argument, yes, 1 in 5 Americans have a mental health condition, but that's like a point prevalence. If you look over one's lifetime, it's 1 in 2 could have a diagnosed condition. And I make the argument that following COVID, maybe 100% of us, because if you look at what an adjustment disorder is, that's a clear stressor followed by, don't test me on DSM criteria, but 3 months, within 3 months, you have elevated symptoms of depression and anxiety. My wife would say, in my case, irritability. That's a mental health condition. And so we're all really suffering. The bad news is that it's kind of the rule of thirds. A third of people will get their depression identified in primary care. Only a third of those will get minimally adequate treatment, like not great treatment, minimally adequate, and only a third of those actually ever get better. So we have a big problem. We took an oath as physicians to do no harm, and our patients just can't stay on the medicines because we're causing a lot of problems. I feel scared saying this thing next to a PTSD expert, but this is kind of what struck a chord with me when it came to pharmacogenomics, and that is, I have a book from 2008, Harrison's Internal Medicine. Now, you all probably don't know what that is, but that's like the Bible it's thick. But then you guys have to read briefings too, so they're probably not as thick as the stuff you have to read. The author on it is Dr. Fauci. You guys heard that name before? Okay. Chapter 5 from my 2008 Dr. Fauci book was on pharmacogenomics, and it says if you're a poor 2D6 metabolizer, so in your liver, you've gotten maybe a bad copy from dad and maybe no copy from mom, so you don't have the copies in your liver to metabolize medicines through 2D6, 1 in 5 Americans are going to have a problem there. You're not going to break down beta blockers as well. And I know we're talking about mental health here, but in PTSD, we use beta blockers sometimes, or our patients have high blood pressure. Your patients are at risk of bronchospasm and bradycardia, and then lowering their blood pressure too much because the beta blocker propranolol is too high in their system. This is from Dr. Fauci. But now imagine that your patient has depression and I put them on Prozac, which goes through 2D6, 2C9, 2C19, and 3A4. And Prozac is a 2D6 inhibitor. And my patient's a poor 2D6 metabolizer. I don't want them on propranolol. And so that's a problem with 2D6 being slow. The opposite problem of 2D6 being too fast is killing people. And that's because codeine, if you're an ultra-rapid 2D6 metabolizer, gets moved more quickly to the active metabolite, which is morphine, and that's killing kids post-tonsillectomy. So that's a black box warning. And we talked about Plavix earlier. There's black box warning there. I'm really glad that we're all here today, but we are so far behind the 8 ball here. Like, this was from 2008. So I really appreciate, I'm from Greenville, South Carolina. I really appreciate Senator Scott co-chairing this work and pushing it forward, but we need to move quickly and have a lot of work to do.
Yeah, thanks, and thank you, Cynthia, for having me today. Thank you to the Coalition for their leadership in this area. I'd like to start by thanking my home state senator, Kirsten Sinema, and her staff, in particular, Sylvia Lee, for sponsoring a programmatic appropriations request that should pave the way for veterans to receive access to pharmacogenetic data and actually have it applied to their ongoing care. Now, the speakers before me spoke very eloquently on pharmacogenetic testing. We're obviously all gathered here today because we have a passion for bettering patient care via precision medicine, and more specifically, the application of genetic data to drug selection. But as I sit here today, the science isn't new. It's been clinically viable since 2010, and not in an effort to take away from my company, but the test is a commodity. Anybody can run the test. The question is, what do we do when the information exists? Because the problem is pharmacogenetics doesn't fit in the current clinical workflow, and the information tends to become obsolete. What I mean by that is the test is once in a lifetime. It's not like COVID, where we tested ourselves every time we became symptomatic. Your genes are the same in 2023 as they are in 2043. And there are very few, if any, providers in America that are looking at pharmacogenetic data to make clinical prescribing decisions 5, 10, and 15 years after this test has been resulted. If you consider that the test was likely ordered by an unaffiliated provider, the odds of someone looking at this information are even less. So information not used, not applied, and not considered is simply worthless. Now, I understand from Cynthia and other people on the Hill that there's lots of people that are sponsoring pharmacogenetic legislation, and I think that's amazing and groundbreaking work. But if the goal is to put a plaque on the wall that says that my legislation changed coverage determinations for a select few beneficiaries despite very little change to actual prescribing, then by all means we need to do things the way they've always been done, which is to put information out into the atmosphere and hope and pray that providers, ungrudgingly in a culture of apathy, spend the time to review 30-page reports that few of them understand. But if we want to be part of real change and we want to impact patient care and cost of care, we need to do things differently. And that starts with how we move the information through the system. Now, my company, we are a lab and we do perform the test, but what we really are is a clinical management tool. The first thing we do is we simplify the data. It is a common misnomer to presume that the average provider understands how to apply this information, despite how easy my competitors make it seem with these red, yellow, and green drug selection options. But more important than simplification, it is how we move the information through the system that ultimately makes it actionable. So my company, Blue Jeans, we have a patent pending API, and its very simplest definition, it is a push and a pull of information. We integrate with PBMs and EMRs. Now, this isn't an assessment of anyone's opinions of a PBM or an EMR, because they are simply vehicles in which we transmit information to make sure that we can impact how prescribing is done. For example, when a script is sent in electronically, we capture data like patient, provider, pharmacy, prescription. Our intelligence queries that data and sends instantaneous notification back saying, do not adjudicate this script. It is not genetically efficacious for patient. At that same moment, we send push notification to all the relevant parties saying the script that was provided is not advisable. Please choose from the following compatible drugs that are genetically compatible. This comes in a format that the providers can easily digest and easily apply. Now, that there are other flaws in standard PGX testing that our software attempts to correct, and we can talk about those later today. I know we're here to focus on the betterment of patient care, but I just want to touch on cost for 1 minute. We're starting a pilot with one of the big 5 insurance companies, and to get them interested, we did 3 insurance actuarial studies. one on opiates, one on SSRIs, and one on Plavix as an individual drug. Just to be brief, I'm going to refer to Plavix only. We took publicly available Medicare data, we extrapolated it against all categories of service, and we were able to show this payer a $4,499 per member per year savings, which is enough to get them interested. In a recent study released by Corial, they found that 5,288 Medicare Advantage members cost $7,000 less over 32 months as compared to 22,000 non-tested members. If we take their data, which, by the way, we feel is incredibly conservative because it was in a controlled environment, and we applied it to all 65 million Medicare members, it's $170 billion in savings per year. But unfortunately, those savings will not be realized with paper tests. Unfortunately, we have to treat patients no matter where and when they seek care. And the only way to do that is to put a fail-safe in the system that protects against catastrophic human error. And it starts with a continuity of flow of information between all providers, not a singular provider. So unless we're playing for a plaque on the wall, we need to do things differently, and we're hoping to be part of that change. So appreciate for everyone having me here.
Let's bring it back to Nathan, and you mentioned all the great work that Mental Health America and others in the community are doing to really serve patients and their loved ones at a community level. Can you just share with us what you and your colleagues hear from the patient community about their experience seeking treatment, and when they do, how difficult is it for them to find the right drug that's going to benefit them? And I know you have some thoughts on PGX and how that might help.
Yeah, so I may take I'll keep it brief, but I'm still going to take the winding road down to the PGX answer. So if you've worked in mental health for as long as we have, or anyone in this room has worked in mental health advocacy, the first barrier to care, of course, to finding care is going to be stigma, right? That's one of the biggest factors in someone seeking care out for the first time. I'm from a small town in Vermont of 800 people. The closest psychiatrist was next town over, and what office? If you had your 1999 Toyota Corolla parked out there, everyone knew you were up the town shrink. Right, and that's very stigmatic. They didn't want to have to go to receive care, and that's the first big barrier to care. So let's say you overcome the stigma, you're feeling pretty good, you go to the MHA website, you take one of our screens, like, oh, this is an issue, and you decide, I'm going to seek treatment. Well, then you have to find a care provider who actually is close to you, like telemedicine aside, right? Maybe you want to find someone who's local to you because you want the in-person care. Well, fine, maybe you find that person. Do they actually treat your condition? Okay, so that's another barrier to care. You have the stigma, finding someone who's going to treat your condition, someone who's close to you, and then you have to find out if they actually accept your insurance or not, right? One of my colleagues, Mary Gilberti, our chief policy officer at MHA, just testified in front of the Senate Finance last month on ghost networks and how these networks are saying we have all these care providers in our networks, but they don't really exist. So that's another barrier to care. So we have stigma, we have finding someone who treats your condition, finding someone close to you, finding someone who accepts your insurance. And then if they don't accept your insurance, we find that the Bowman Family Foundation survey that came out during the past week, most people are trying to find care providers out of network because most people aren't in network. And that's 57% of adults and almost over 80% of adolescents are finding care out of network. So when you're going to try to find help, you have all these barriers first before you even want to get to whether or not you're going to be on a medication that works for you. So let's say you get past all those barriers to care. And you find someone who's going to treat you, psychiatrist is going to treat you, and then you find a medication that hopefully is going to work for your depression. Well, then another barrier to care is perhaps that in that practice that the physician is going to submit your prescription for prior authorization. If you're familiar with prior authorization, you have to have the insurance company approve this medication, saying, yes, now we can treat you with this medication. Let's say you get past that barrier to care. Then you have to wait to see if that medication works for you. And if you're familiar with SSRIs and some other meds, you can be waiting 4, 6, 12 weeks for that medication to see if it's going to work for you. And I think the stat may be wrong. It's something like close to a quarter of the antidepressants are not necessarily working the first time around. So now you're a patient who's overcome all those barriers. And now you've waited 12 weeks for the depression med to help you to feel better and live the life you want to live. And then that doesn't work. So then you're going to be put on a second medication. You're going to wait another 4, 6, 12 weeks. So all these things are barriers to care. And when it comes to PGX, really, it's going to be another tool in the toolbox to help you get the care you need when you need it from whom you need it. And, the Human Genome Project finished in 2002, 2003, And then just last year in 2022, they sequenced like the last 7 or 8% of the human genome. So we're really on the cusp of a lot of potential to get a lot more information into the hands of the provider, of the doctor, and the patient, the person with lived experience, so that they can have a conversation about what's going to work for them. A lot of insurance companies, including some Medicaid programs, but MHA has been advocating pretty strongly against these in many states. They have what's called the fail first sequence of events. So the medication has to fail you first before we'll try you on another medication. This is also called step therapy, if you've heard of step therapy. And so what I think the promise of PGX is, and again, going back to our strategic plan of next-gen prevention, is it's going to be another tool in the toolbox for the clinician to have a conversation with their patient to figure out what's right for them so that they're not continually being failed by the medications they're put on the first time.
Thanks so much. So in Nick's intro, he referenced the Kentucky Teachers Retirement System and the savings that they found when they implemented pharmacogenomics in their Medicare Advantage beneficiary population. But that was really pharmacogenomics in the wild, so to speak, because it wasn't something that was designed as a study to see how pharmacogenomics worked and how much money they were actually going to save, which is why the estimates were pretty conservative. But the study that Dr. Oslin's running and that he and his colleagues published recently were looking specifically at pharmacogenomics. So Dr. Oslin, can you share a little bit more about that and what you all learned from that?
So first thing, thank you guys for funding the VA. We very much appreciate it. I've loved taking care of veterans for 30 years. It's been really a career full of grace and hope in taking care of veterans. So thank you for paying for myself. So the VA, for those that don't know who we serve veterans, obviously, but really we are, in a lot of ways, a safety net organization for veterans. We don't serve all veterans. You guys don't open the checkbook to serve all veterans, so we typically served a lot of disenfranchised or those veterans that have struggled after they've served our country. What that means is that the population that we see in the VA is very much enriched for folks with mental health issues. PTSD, depression, substance abuse being the most prominent three. About 1 in 2 veterans that we see in the health system will have a mental health problem. So every other patient that walks in the door has a diagnosable disorder. So the VA is very, very interested in how we can do a better job. Any given day, there's close to 4 million veterans that are on an antidepressant. So if we can move the needle a little bit for those 4 million in terms of better efficacy or better outcomes, that's a great win from a public health perspective or population health perspective. So about 4 or 5 years ago, there was a great deal of interest. Is there enough data? Is there enough evidence to start to move this into the field and start to bring population pharmacogenetic testing to providers? And we had a lot of discussions and so forth about how to do this, and there's really 3 elephants in the room. One is there's a lot of genes, and they don't all have the same evidence level. So which ones have the most evidence that we want to put into practice, and who gets to decide that? So which test or tests do you do? Which panel do you use? It's a lot of decisions on what actually to test, which ones might be more efficacious, and et cetera. 2 is how do you educate the workforce? So we're very interested in this issue. We have a workforce. When I did take a genetics class 30 years ago in medical school, but I don't think we learned a lot about. I had a Harrison's textbook as well. I don't think it had a pharmacogenetics section in it. So we have a lot of providers that don't know a lot about pharmacogenetics. And then the 3rd elephant in the room is informatics, and Nick touched on this. This is a very different test than getting your hemoglobin checked or getting your blood glucose checked. It's a lifetime test for the most part. I'm hoping that in 5 or 6 years we'll have other genes to look at, so there will be times that we will need to retest patients clearly as we discover more. So the the sort of the solution that the VA came up with is the notion of trying to do a large-scale study to move both the needle within the VA, but also for the good of the public. And so we designed a study that was a very pragmatically designed study where we would use frontline providers. We would develop an educational program for those providers, teach providers how to interpret the test, how to use it, what to say to their patients, how to introduce it to their patients, et cetera. And then we would secondarily look at whether having this information actually moved the needle on treatment response. And so that paper came out in JAMA of last year. It stands currently as probably the largest, and it will for quite a number of years. It was a big undertaking, both financially and just doing the study. About 2,000 veterans participated, about 600 providers participated in the study. And so here are the nutshell outcomes of that. So I wouldn't be here if it wasn't a positive trial, I don't think. So the first question that we really wanted to address is, would providers use the information? Could we teach them to use it? And would they prescribe differently? So as Nate said, the sad truth is that antidepressants, the first time you take them, probably a third of patients will respond to that with some good evidence, with some good outcomes, not necessarily to remission, but to some good outcomes. That means 2/3 not. The 2/3 that's not needs another trial, another treatment. Could be psychotherapy, it could be another med. You pick up another third and a third and a third, and you can see that really quickly this doesn't do well if you want to get better. The other thing that Nate didn't mention is every trial, patients get frustrated with treatment and stop coming. So with every time that you have to sort of start over, tell your story over, or start back on another medicine, the chances of you sticking with that next treatment dramatically go down. So when we don't get our treatments right, or the quality of our treatment right from the beginning, we lose patients in terms of them sticking with us. So the first question was providers actually take this information, use it, prescribe differently? And that actually was, it wasn't such a simple task to teach providers. Lots of variability, and could talk about that all day in terms of their knowledge, what they actually think the test told them, how do they use it, how do they explain it to patients, et cetera. But overwhelmingly, there was a major shift in how they prescribed. So they prescribed essentially away from medicines that had drug-gene interactions. The nice thing in our field is we have lots of antidepressants. There's really not much difference between one and another, except for side effects and maybe efficacy now in terms of metabolism. So prescribing was very different in the folks that had the test results available to guide their treatment. And then the question was, do patients get better? That's really the ultimate question, right? So the answer is yes. They got better, about a 1.3 odds ratio of getting better than if you didn't have the test. Now, the skeptics with PGX, and there's still a lot of skeptics, would say that that's a pretty small effect. And the folks that believe in it would say that's a whopping effect. So I think you have to decide if you're a glass half full, glass half empty kind of person to take these results and think about them as positive. Here's the way that I think about the results. And the VA study actually, shockingly, was exactly the same as many of the others. The results we got were no different than the other studies that have really been done in this. So veterans respond just as well to antidepressants and treatment as non-veterans. Here's the way I think about the test results and where we are with this. Not everybody that's going to get a test is the test going to tell them something about that treatment. Actually, it's only about 15 to 20% of the patients. If I was prescribing drug X, and Nate, I'll just use you as an example, Nate. If you and I had a discussion and I was going to prescribe drug X for Nate to treat his depression, and I said, well, before we do that, let me get a pharmacogenetic test. About 15 to 20% of the time, that test would steer me away from that medicine that I would pick. So not in everybody. It's not going to suddenly tell me, no, I shouldn't pick drug X. I should treat you with drug Y because you're going to get better from drug Y. It doesn't tell you that. What it tells me is that drug X for him has the potential for more side effects and probably or lack of efficacy. So it doesn't help me in every single patient. And that was actually a big learning lesson for a lot of providers. They were like, oh, I got this test back, but this was the drug I was going to use anyway. And then the other piece of this is sort of the long-term nature of this. What if it doesn't guarantee that you're going to respond to that medicine just because you didn't have a drug gene interaction with that medicine. So there are times that you still are going to need a second drug, or you may drop out of care and come back to care 6 months later or a year later. Who's going to remember that you had that test done? So for us in the VA, this is a big informatics issue that we're working on. We actually have now point of prescription. So when I go in to prescribe an antidepressant or clopidogrel or many other meds, it'll actually pop up tramadol, codeine. It'll pop up and tell me, no, this person's been genetically tested and you may want to think about something different at the point of that the point that I'm writing that prescription. So that's sort of where we are. Lots, I think, still to do. There's not a standard from company to company in terms of either the drugs that they are testing or the level of evidence for the different genes. There's a lot of you get different answers from different companies sometimes in terms of their recommendations, and so there's some work to be done in that space as well. But happy to answer questions in a few minutes.
I would say that work is being done. My colleague Daryl Pritchard and I are a part of FDA-recognized collaborative community called STRIPE, and it's looking to standardize information around drug-gene interactions and how that's reported. So it's a lot of work, but it's work that's
it's very neat.
And I would say continue to fund the VA. My dad receives his care and is actually what's considered to be 120% disabled. I didn't even know that was a thing, but he's doing well in the VA care. So Dr. Felkel, you, I would say, were not a early believer in pharmacogenomics based on a video that I've seen, but you had a particular experience with the test called GeneSight and a patient that helped to change your mind about how it could potentially improve your practice as a tool. So can you tell us a little bit about what your initial hesitancy was around PGX testing and how that experience really changed how you operate in a sense?
Sure. And I guess this is a cautionary tale to not put stuff on YouTube, right?
Oh, yeah.
I remember the year I was 2015. I was walking through. I did all my training at Wake Forest, Winston-Salem. It was the APA conference, and I refused to go up to any pharmacogenomic tables vendors because I was like, they're going to give my patient a big bill. They're going to break my rapport with the patient, which is the most important. It's like pseudoscience, etc. The studies hadn't really panned out to date. But it took another psychiatrist getting my patient well to get the ball rolling for me, despite my book from 2008. In walks Ethan one day. That's not his real name, but we'll call him Ethan. And I'm big on co-located care and measurement-based care. So Ethan walks in one day, and his hands are like this, and he's staring down at the ground. He's selectively mute, so he's not talking to me. And his knuckles are just almost bloody because he's been hand washing too much. So I do a children's Yale Brown obsessive compulsive scale, and it's severe. His obsessions are around being contaminated, and then his compulsions are to wash his hands to cleanse himself, to reduce his anxiety. And I do a PHQ-9. He's got major depression also. A lot of conditions run together. Dad runs a Christian nonprofit in town, and mom is a principal at a local school. So not a ton of like social determinants of health issues going on. I always screen for those as well. But there's something that felt more like just pure genetic, biological, not kind of psychosocial. So I did what any child psychiatrist knows how to do, and that's get him into the best exposure response therapist. Psychotherapy is so important. A lot of people worry about SSRIs and kids' suicide risk. And suicide numbers are really going up. But if you're in therapy, that helps protect against it. So this psychologist would work with him for 2 years, weekly, sometimes more than an hour, and he would have to touch things like a toilet seat from Home Depot, straight out of the box. But that was like a clean toilet seat, and you would have to sit with that feeling and kind of push through. That's exposure response therapy. that wasn't really helping. So I started Zoloft, sertraline, and I got him all the way up to 200 milligrams, the max dose. You kind of need higher doses of serotonin for OCD. And his parents were getting frustrated with me, so they hospitalized him for his OCD at a Rogers specialty facility in Tampa. He went down there and they put him on Abilify. I bet that psychiatrist at the time didn't know that Abilify actually has a warning in the package insert. If you're a poor 2D6 metabolizer, you're supposed to start half the initial dose. And most of our meds have these, just psychiatrists, primary care, no one actually reads these. So start half the initial dose, and if you're a poor 3A4 metabolizer or on a 3A4 inhibitor, you're supposed to start a quarter of the initial dose. So this might be like Abilify 1 milligrams every other day, but in the community, I was on to OBGYN the other day, he starts everyone on 5, which I probably would not do. So Ethan comes back to me on Abilify and on the Zoloft, and he's gained 40 pounds very quickly. There's something about his DNA that's just having problems with this, and there's probably some metabolic gene out there that's playing some role. I take him off the Zoloft and the Abilify and put him on Prozac, fluoxetine. Like I said before, 2D6 substrate and inhibitor. And I remember the day because their family's leaving my office, and I get a call that he tried to jump out of the car. There's something about my Prozac that is activating him. And sometimes it could be like inducing a manic episode, but this was just kind of making him restless. He's more prone to side effects, even at low doses. So I stopped that, got an EKG, and started him on clomipramine. It's a TCA. You all may not have heard these, not prescribed as much, but if you've had migraines, you go to the neurologist and you're sleeping well, you get put on nortriptyline. If you're not sleeping, you get amitriptyline. If you go to the GI doc and you have like a functional abdominal irritable bowel syndrome, you get on these very complicated medicines that even as a psychiatrist, I'm a little nervous using. So I do that. His parents have lost all faith in me. I'm frustrated with myself, and they hospitalize him again. And that psychiatrist does a gene site. This is 2 years into the road. And it comes back, he's a poor 2D6 metabolizer. He's short at SLC6A4. That's the serotonin gene. And another of different pathways. This psychiatrist puts him on Cymbalta, duloxetine, not FDA approved in kids, and I'd never use it for OCD. And Ethan had a complete remission. 2 identical hospitalizations, therapy the whole time, and then remission. And do you all know what Cow Day is at Chick-fil-A? Do you have that? I see some nods. That's good. Cow Day at Chick-fil-A is if you dress up like a cow, you get free food. Okay? And my wife is very thrifty, and she makes us dress up like cows, and we go to 3 different Chick-fil-A's, breakfast, lunch, and dinner, to get free food. So I walk into Chick-fil-A, and Ethan is there working. And the great psychiatrist I am, I didn't even know he was working at Chick-fil-A. He's taking money, which is super contaminated. He's handing out food. He's saying, "My pleasure." Great eye contact, of course. He's stone cold back to his typical self. I had never seen him like that, and I was left feeling so guilty that it was another psychiatrist that did a gene site got him well. These stories, as I've traveled across the country, happen over and over and over again. What you've heard from these studies is population statistics, and GeneSight does have a study using a combinatorial approach, 50% improvement in remission rates when a psychiatrist has access to GeneSight. It can move someone from a red, yellow to a green bin. At the point of care, though, we're also thinking about blood levels and interactions of medicines. And so Ethan made me a believer and started this journey along pharmacogenomics.
What would you say, it sounds like there's a lot of providers, even in the VA system, who needed education on pharmacogenomics. I mean, what are some of the barriers that sort of led to your initial hesitancy around PGX? And, if for a doctor that doesn't have the sort of like a definitive experience where they see the benefit of it, what are some of the things they need to overcome?
Yeah. We need more studies. Let me give you an example of how complicated this gets. This is my understanding, but it could have already changed by now. And this kind of addresses your point around single gene testing. Who's heard of Wellbutrin, bupropion? It's a really great antidepressant. Works on norepinephrine, dopamine, not just serotonin. So it's very different. Our serotonin meds are good at turning down the bad, not great at turning up the good. Wellbutrin's a little bit good at turning up the good. because it works on dopamine. Wellbutrin goes from bupropion to hydroxybupropion, kind of its active metabolite, through 2B6, and then gets cleared through 2D6. So if I did a test that's single gene and you were ultra rapid at 2B6, so I'm thinking it's clearing more quickly, I'm going to go up on the dose. But if you're a poor metabolizer at 2D6, you're building a dam and shunting towards the active metabolite that also can cause seizures. So if another tool told me ultra rapid 2B6, I might increase it, whereas having a combinatorial bin approach would actually tell me not to use Wellbutrin. I bring that up to say that when you test with two different tests, you get different results. And the providers at the point of care are getting kind of caught in the middle. And we need more forums like this to study it, push the science. Just because we have a blood level doesn't mean brain level, because we still don't really understand the blood-brain barrier proteins. I really like CPIC. It's a great organization. They make recommendations to the FDA. They put in these package inserts. CPIC says if you're a poor 2C19 metabolizer or ultra rapid, Lexapro is just not going to work. And that is my go-to in pediatric psych. And so it's not really about the blood level necessarily. It's about there's something we don't really understand that med just doesn't work. So it takes a lot of education. Yeah.
And we're going to have one more question for the panel, and then if you all have questions, we'll turn it over to you. Nick, you did talk a bit about the role that technology and software and other applications outside of the actual test play. Is there anything else you want to say about that, and after everything you've heard from your fellow panelists?
Yeah, I mean, first of all, I'm an evangelist for pharmacogenetics. I think everyone should have it, no matter what format it comes in. And I understand that we feel like there's success at the current VA program and other ways. But unfortunately, in most scenarios, it's not reality, it's fantasy. And what I mean by that, a lot of these studies are controlled environments where the providers, A, are aware that the test exists. It's the first big thing. B, they know how to interpret the data, and they've been instructed on when to use it. And that's not the real world. Let me give you a brief fictitious example. Let's say we've got a Medicare patient from Michigan. Actually, scratch that. I'm an Ohio State Buckeye. They're from Ohio. So this is a Medicare patient with 3 chronic conditions, cancer, cardiac disease, and diabetes. Let's say the family moves the patient to Florida because they want to better take care of her. Pretty typical situation. So in Ohio, rather, she had a rheumatologist, a primary care, a cardiologist, oncologist, and the list goes on. Now she's got the same set of doctors in Florida. What are the odds that the Florida doctors have consulted with the Ohio doctors and they understand that a test exists? I'm going to tell you got better odds in Vegas. And then miraculously, let's say that the primary care does get it, understands that the test exists, and knows how to use it. What are the odds he coordinates care with the other 5 physicians in Florida? It's not going to happen. At least not 99 out of 100 times. It's not going to happen. So, my case in point is there was a Senate hearing 30 days ago here, and it was on opiate prescribing in the VA and how do we taper these drugs. And it's really, really powerful. If you haven't seen it, we can send it to you. I suggest you watch it. It's really shocking. So the woman testifying takes out her medications. And by the way, she's both a provider and a patient of the VA. She takes out 15 different medications, and she says, I didn't ask for any of these for my back pain. They were given to me, and they were told they would fix them. She goes, I understand adverse drug reaction. I'm a healthcare provider. I understand if I take this one and this one, I'm not going to wake up. The average vet doesn't know that information. Now, the representative from the Office of Inspector General, by no fault of her own, she was not involved in the care, her only response was, it's a catastrophic failure in care. That's drug to drug. Every pharmacy, every PBM, every EMR purports to have a drug to drug calculator to resolve these issues, yet this still happens. So unless we take our head out of the sand and we think that, the average provider can coordinate care for a patient with multiple drug doctors when they can't do drug to drug right, and we expect gene to drug to go right, without some sort of technological intervention, we're kidding ourselves. We're just, again, playing for that plaque on the wall to say we did something. You're not going to impact care. And that's not an assessment of any provider's capacity. It's not disrespectful. They have too many things on their agenda, and we're unduly burdening these providers with more and more requirements like pre-authorization. To Nate's point, they got 18 things they need to do to treat a patient. So the only way to make this work, quite frankly, is to put a fail-safe in the system. It's a red flag. The answer is no, don't prescribe it. So that's our position.
I highly recommend you read the Prime Care study. I'm not a scientist and I actually understood it. So I do recommend you read it, even if you don't have a scientific background. But one of the reasons why the Kentucky Teachers Retirement System study, call it a study, but it's not a study, the reason that their application of pharmacogenomics worked so well was because it was coupled with active medication management once there were findings from the pharmacogenomic testing, and that was in part mediated by a pharmacist who could inform the decisions around changes in medication. So that's another study. It's actually linked in the overview for the Caucus. It's the very end. I recommend you read that as well because it was a good application, and they're very passionate about the use of pharmacogenomics. We have a few minutes left, and I'd love to hear from you and any questions you have. Just let us know who you are and where you're from. The sugar coma hit already. Jen.
Last one.
Yep, Jen.
Hi, Jen Walsh with Foley and Lardner, and we work with the Personalized Medicine Coalition on the Congressional Caucus. I'm just wondering, what should a patient do when they are faced with, potentially being prescribed medication or pursuing the correct course of treatment? I mean, should they ask their doctor to run one of these tests? Does insurance cover it? I mean, how would you advise patients? And I realize that's kind of a loaded question because this is unfortunately still somewhat in its infancy, but just practically speaking, I think that would be really useful to hear. Thanks.
I can start. I mean, so not with my VA hat on, but just on my provider hat on. I mean, any patient that wants to get tested, we would have a discussion about the value of it and what it would do for us. The testing is, I think Nate mentioned earlier, is one tool in our toolkit in terms of trying to decide about prescribing. It's a good tool, but it's not the only tool. So, there's a consent process, making sure that the patient understands what the test results are going to tell us. Now, I'm an informed provider, and it's like Carson's an informed provider. The reality is most providers have no idea what these tests do and what they provide to them. So that's a huge issue. A lot of patients might ask their provider, and their provider really has zero knowledge about the test or how to use it or where to go. And then there's like 30 different tests on the market, at least 30 different companies, and maybe even more now. Which one do you go to? They all have different panels. Some of them have single genes, some of them have panels. Who's to know whether one's better or not? So there's a lot of that kind of stuff that's not worked out. I think, if I'm that provider that doesn't know what I'm doing, I'm going to try to find some of my colleague that does know something about this so that we can make an informed decision. We don't want a patient just to go randomly, let's go to that vendor because they were in my office last week and I just recognized the name. So I think there's still a lot of education we have to do. I can't speak to the insurance piece of this. I think some insurance carriers cover it, some don't. I fortunately don't have to worry about that in the VA. We offer testing to basically anybody that wants it as a veteran. I will mention there's one other thing for you guys to be concerned about. Not all patients want testing. Some of them are scared to death of getting genetic testing, and that's something that you have to deal with as well. The notion that I'm going to test something in their genes there's a stigma there for many, many patients. And that's something that we still need to deal with in terms of personalized medicine as well.
I'm a strong believer that the patients are consumers and we need to be more consumer centric. And so specifically to your question, I would recommend going to websites, CPIC, farmgkb.com or farmgkb.org. I'm not sure which one. And then Myriad Neuroscience GeneSight has a number of white papers that have really informed my understanding. I currently utilize their test because I do believe in the combinatorial approach, and also that it has a big study to support it. Being evidence-based is really important to me. There's other genes out there to find more information on. So far, these studies are depression, and patients had to have failed 1+ medicines, but on average, they had failed more meds. Certain degrees of depression to enter the study. But there's other genes out there. MTHFR is a big one that I think the science is emerging around it. Some believe in it, some don't believe in it. I believe in it, and I think that activating folic acid is super important in our health. There's COMT genes that don't have big studies, but I would want my patients to educate themselves about it. I don't find harm in that. You have to know your patient, though, because some will go down a rabbit hole or get paranoid.
And 2 points on that. The Personalized Medicine Coalition, we work in 3 areas: evidence development, education, and advocacy. So you didn't hear a lot about the work that my colleague does in evidence generation. So if you want to talk to him afterwards, he does quite a bit of work in pharmacogenomics, right there, for sure. And then there's also a component of the pharmacogenomics legislative package that Representative Swalwell is working to reintroduce that is looking to provide additional funding for the National Institutes of Health for both a provider and patient education campaign in pharmacogenomics. So it's worthwhile to take a look at that. We're a little over time, and it's wonderful that you all decided to stick around. I just want to thank you on behalf of the Personalized Medicine Coalition for coming here, and thanks to our speakers for their really thoughtful preparation and efforts to get here in person. We're sending folks back to, I think, areas where it's hotter in the country. It's hard to believe. For the congressional staff who joined today, there's information on the Personalized Medicine Caucus. Would love to talk to you more about it. If your bosses are if this is something your boss would be interested in, you can contact me directly. You can get in touch with the points of contact for that. And then I'd just like to close by recognizing Representative Swalwell, Senator Sinema, and Senator Scott's staff, as well as Josh Eisman, Jen Walsh, and Bill Ball at Foley and Lardner. Without you, the briefing wouldn't happen. Without Lucas, there wouldn't be ice cream. So you can thank him for that. And without you, today's program really wouldn't have been possible. So thank you very much. And hope you all have a great rest of your day.
Pleasure to meet you.
Yeah, get home to those kiddos.
Pleasure to meet you.